Hi everyone, welcome back to the channel. Today we're going inside the operating room to show you exactly how orthopedic surgeons fix a broken kneecap, medically known as a patella fracture. Let's start with what a normal patella looks like on x-ray. Here you can see a smooth rounded bone sitting in front of the knee joint. The patella acts like a shield for your knee and gives your quadriceps muscles a mechanical advantage when you straighten your leg. Now, let's look at some fractured patellas. These fractures usually occur from a direct blow, a fall onto the knee, a dashboard injury in a car accident, a motorcycle wreck. When the pieces separate, you lose the ability to actively straighten your knee, and surgery is often needed to put the bone back together. The patients you're seeing first had open fractures, meaning the broken bone came through the skin. Anytime a fracture is open, our very first step is thorough irrigation and debridement. We use several liters of saline to wash out dirt, debris, and bacteria, and we carefully remove any dead or contaminated tissue. Only after the wound is clean do we move on to definitive fixation of the fracture. Given the severity of the fracture, there are multiple ways to fix a broken patella. During this video, we will demonstrate two fixation techniques, with one being an approach for straightforward fracture patterns, and two being an approach for a severely damaged patella with multiple fractured pieces. With the knee prepped and draped, we mark our midline incision directly over the patella. A straight anterior approach gives us the best access to the fracture and the extensor mechanism. The outline drawn on the skin prior to incision helps to not only make the most appropriate dissection, but to also help give us reference of the skin edges when we close the wound at the end of surgery. We make the skin incision with a scalpel and then carefully dissect down through the subcutaneous tissue. We work in layers to preserve as much soft tissue as possible. This helps with healing and reduces scarring. We next use tissue scissors and forceps to continue the dissection. Here you can see the fracture itself and the torn retinaculum on both sides of the patella. The quadriceps tendon above and the patellar tendon below are still attached to their respective fragments. The key to a good outcome is anatomic reduction, getting the joint surface as smooth as possible. We use a large pointed reduction clamp to bring the fragments together and then check our reduction with the C-arm, an intraoperative x-ray machine. You can see the articular surface lining up perfectly here. If we are happy with the reduction, we place a temporary wire from the bottom of the patella to the top to hold everything stable while we place our permanent fixation. We drill directly over the wire and place cannulated screws. The screws compress the fracture site and give us strong anchors for the next step. Because the screws are cannulated, we can pass a stainless steel cable in a figure-of-8 pattern through the screws and around the front of the patella. When we tighten this cable, it converts the pulling forces from the quadriceps into compression across the fracture, exactly what we want for healing. We tighten the cable with a tensioner device until we feel good resistance, and then use a crimping tool to ensure that the cable will never loosen. The cable is then cut short and tucked away so that it won't irritate the skin. Here are the final x-rays using the screw and cable technique. You can see the fracture is compressed, the joint surface is restored, and the hardware is low profile. But not every patella fracture is this clean. When the bone is shattered into multiple small pieces, the tension band technique alone is not enough. For more complex injuries, we use a dedicated patella plate, sometimes called a star plate because of its shape. The plate is malleable so we can contour it to match the patient's exact anatomy. Multiple small fragments are captured with wires first to restore preliminary alignment and stability of the fracture. Then we secure the plate with locking screws from many different angles to create a true cage that holds all the smaller pieces together. Multiple small fractures are captured with wires first to restore preliminary alignment and stability of the fracture. Then we secure the plate with locking screws from many different angles to create a true cage that holds all the smaller pieces together. You will see us drilling through the plate into the bone, using a depth gauge to measure length, and then inserting the appropriately sized locking screws into the plate. This process is continued circumferentially around the plate until we have adequate fixation to the bone. Once all hardware is implanted, we get final X-ray images to confirm proper anatomic alignment of the patella fracture. Here we can clearly see the amazing restoration of a once severely fractured bone to a fully functional repair. Once all the bony work is complete, we move to the next phase of surgery, which is to close up and repair the soft tissue layers. We start by using a strong suture called fiber wire to provide additional stability to the knee. This stitch is performed in circular fashion around the knee joint to include the quadriceps tendon, the patellar tendon, and the retinaculum of the kneecap. Once that stitch is complete, we use a dissolvable suture to close the next deepest layer of tissue. The goal with each layer of stitching is to provide structural and functional support to the patella, but also minimize infection risks. On the most superficial level of tissue, we use our previously marked outlines to bring the skin edges together. We use a thinner dissolvable suture for this layer. Upon completion of our suture repair, we use staples for the final closure on the top layer of skin, thus concluding patella fracture surgery. As we review the images of patellar surgery, we hope you've enjoyed this dive into the operating room. Make sure to like this video and subscribe to the channel for more point-of-view experiences of orthopedic fracture care.